Okay. And I'm going to put us live on Facebook. And so people will start coming in. I don't see anyone yet, though. All right. So, Mind Health Shop Talk. And so we should be going live. And then I'll also be able to give you the questions that are on Facebook. So that way, just in case. So we have 6 people in. Hello, everyone. Welcome. And then I'm going to share my little PowerPoint. I have your, you know what? I don't have, Susanna, I don't have your picture.
That's
to introduce
fine.
you.
I am literally nobody in this. You have 2 of our finest. I am nothing.
You
I'm nothing to
are.
this.
Don't say that. We're glad you are here. So welcome, everyone. We'll get started in a second. Just wanted to, I'll have that on there while we're doing this. So this is our nice little flyer for our irritability, severe irritability and anxiety in youth for our Mind Health Shop Talk. So welcome, guys. I know we have a couple of people watching us on Facebook as well. We're going to give everyone a couple more minutes to come in. Usually we're in the beauty shops and beauty salons, and we'll be eating and drinking our little refreshments and stuff. But hopefully in the fall, if COVID doesn't sidetrack those plans, we'll be back in person and being able to just eat refreshments together and chill out together. That's my hope. That's my hope at this point. So hopefully everyone got to go outside and enjoy the nice weather. I'm trying to expand my screen, but I guess it doesn't want me to see everyone. So welcome. We're going to give it a couple more minutes, and then we are going to start. Usually we have a little icebreaker, so maybe this will be a good time to do that. For the last 24 hours, if you put in the chat the top emotion you have, if you were happy, sad, disappointed, angry, any of those things, put it. And if you message me, I'll pick the person that wins the first response for that. And if you send me your address, I'll send you a journal. We have a couple of extra journals, but I still want everyone to participate. How about that? Everyone still participate, but the first person, not Dr. Warren, will get a journal. All right. So Ms. Zakia
Got me in there,
Kennedy.
Roxana.
You said what?
You got me on that one.
So please message me, Zakia, and I can send you a journal. I'm gonna give 2. So you know what? We're gonna give Dr. Warren something. We're gonna give all the panelists will get our some swag, because I know Dr. Warren just started with the Mind Health Shop Talk initiative. So we'll do that. And our awesome presenters tonight, which I'll introduce you to, will get some BMH swag. So some of the responses that we have are very fitting for right now, right? Concerned, frustrated, happy, overwhelmed. And look, you can feel those things probably in the same couple of minutes, right? Don't watch the news and feel good, because that'll just ruin it right there. Ms. Kathy said tired. So yeah, definitely all valid feelings right now, especially the end of the day. So we're glad that you're here with us though. And I think we're gonna go ahead and get started. Thank you guys so much for joining us for this Mind Health Shop Talk, Severe Irritability, Anxiety in Youth. I just wanted to talk a little bit today because of our, So I'll talk a little bit about our partnership with Black Mental Health Alliance and Kaiser Permanente. I just wanted to let you guys know that for our Mind Health Shop Talks, we are usually in our beauty shops and barber shops the pandemic, we've been virtual. This partnership with Kaiser Permanente is the mental health and mental development part. The Kaiser Permanente goes to different barbershops and beauty salons in Baltimore City and actually will take services to the community. So the Mind Health Shop Talk is just a branch of that. So we're very glad to be partners with them. And what I will do is I'm going to just go over a little bit of what we really wanted to talk about tonight, which we did not plan on this, unfortunately, but because of the shooting that has gone this weekend in Buffalo, New York, I thought that this quote would be very fitting because really we need to have a space where we're open for healing and just being authentic to the moment. That's why I said some of those responses to the emotions that you had in the last 24 hours were so fitting. But I looked up quotes that I could possibly share around trauma, and there were so many, I couldn't believe how many quotes there were. And then I put racial trauma, and this was one of the top quotes. Darkness cannot drive out darkness. Only light can do that. Hate cannot drive out hate. Only love can do that. And that's by Dr. Martin Luther King Jr., Strength to Love. So I just wanted to share that with us as we're getting started today. And so I want to introduce our Kaiser Permanente representative, Dr. Tati Warren. She is new to our arm of the Good Health, Great Hair Mind Health Shop Talk. She's a consultant for the Mid-Atlantic region. Hello, Dr. Warren. Thank you for joining us tonight.
Thank you so much, Roxana. And I'm excited, just like you, for the conversation. My heart goes out to the families of lost loved ones in Buffalo, New York. I am actually in the state of New York tuning in this evening, and I'm bringing once again greetings on behalf of Kaiser Permanente. I do want to share some programmatic updates that we've had in partnership with Black Mental Health Alliance and our Good Health and Great Hair initiative. We just concluded our partnership with Maryland State Health Department for the Go Vax COVID-19 vaccination program. Woohoo!
Yes, I know you guys have done a lot of work around that.
We've done a lot of work, yes, indeed, and we could not do it without our trusted partners, Black Mental Health Alliance included, but definitely our barbershops and salon owners. We were able to serve over 61,000 Marylanders in giving vaccine equity and education, hosting pop-up events, using both barbershops and salons across 3 counties, Baltimore City, Prince George's, and Montgomery County. And we did that in the space of 10 barbershops and salons, 65 school partners. We're having a conversation tonight around our youth and anxiety. And so it's so important to continue to partner with schools. And then, of course, our faith-based communities and other organizations alike. This initiative has been phenomenal, and it's been phenomenal to serve over the past 9 months. We've been able to host over 70 vaccination pop-up events throughout the state of Maryland. Over nearly 10,000 vaccine referrals, and using our community health workers to help canvass and reach those who are underserved and under-resourced. So I'm excited to bring those updates. This here on the screen is just a slide representing some of our key programmatic successes. I'm excited to continue with this initiative, but more importantly, to continue with the Mind Health Shop Talk throughout the rest of this year, serving Baltimore City. So we're excited for the conversation today, and we're excited for to get back into shops and continue to have these engaging conversations. So thank you again. I'm Dr. Tatiana Warren, serving as Kaiser Permanente consultant, program evaluation consultant in the Mid-Atlantic region.
Thank you so much. I know we've never even met. Been months already. So yes, I can't wait till we get back into the shops. For Mind Health Shop, I'm sorry, on behalf of the Black Mental Health Alliance, I just wanted to do a little bit of an overview of what we do. Andrea is not going to be here today. We're trying to get some boots on the ground for Buffalo, New York community that's being affected by the trauma of racism, the violence that occurred over there. So she's trying to organize that now as we're speaking. So I apologize for her not being here, but I just wanted to let you know what BMHA does. We serve the community and organizations throughout the area by providing workshops and forums covering a wide range of topics and subjects. And we also offer the community an opportunity to connect with culturally competent, patient-centered licensed mental health clinicians through our expansive referral database. And with that, it's a totally free service where our resource referral manager, Cheryl Maxwell, will ask you a series of questions about your insurance, what kind of help you need. If you need free services, she has programs and therapists that are donating their time for that. So really, we don't want you to walk away thinking any of the services you have to pay to get assistance. There's a lot of free programs, and even your job may have some support. So please contact Cheryl Maxwell, and I'll drop her phone number in the chat so she can help you with that, especially with the topic we're talking about today. So for our session today, we're going to be joined by clinical psychologist and two clinical psychologists, Dr. Ramaris E and Dr. Jamell White. And we'll dive into the month's topic of severe irritability and anxiety in youth. Parents and teachers, we all know how it is dealing with a moody young person, and the questions that are frequently asked are what's the right time to go and get help, right? So that's what we're going to be talking about tonight. But I didn't have this beautiful lady's picture to put up, so I decided to stop sharing the screen. So Ms. Susanna Sung from the National Institute of Mental Health, she's going to just go over some of the awesome things that they're doing in their division for young people and children. So I'm going to pass that baton over to you.
Thank you so much, Roxana. We are so excited to be working and partnering with you. So impressed with the work that you guys do. This is our first and hopefully a long relationship of partnering up together to bring mental health education to the public. So we are coming to you today from the National Institute of Mental Health. We are the nation's biomedical research agency to study mental illnesses. And so our mission is to transform the understanding and treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. And we fulfill that mission by supporting and conducting research on mental illnesses and the underlying basic science of brain and behavior. And we could not make any of these discoveries without our volunteers, so we thank them so much. We conduct research studies for adults and children for depression, anxiety, irritability, schizophrenia, postpartum, premenstrual, and postmenopausal depression, healthy volunteers, and many others. And you can find out more by reaching out to us. Roxana's got my information that she can drop in there to reach out to us. Also, we have a lot of free publications about all kinds of disorders. We have lots of free videos and other online resources that you can use. You can find those at www.nih.nih.gov, or again, by contacting me. And we are also available to partner up for additional educational workshops as well. So thank you so much for having us.
Yeah, so, and we are just, I forgot to say that this partnership happened by outreach, and we really want to make sure that in the communities that we're dealing with, if you're at a school or if you're at a church, any of those places, that there are organizations that are willing to do trainings for you. And we're one of the organizations, and this Department of NIH Mental Health is willing to do that as well. So please reach out to us and we can connect you with them as well. So with that, I'm going to introduce our speakers for tonight. So first, I wanted to introduce Dr. Ramaris E, and she is, wait a minute, I got to scroll down because she has a lot of letters behind her name. She's a clinical psychologist in neuroscience and novel therapy at Novel Therapeutics Unit. And she has a broad range of clinical research and training experience with children, family, and adults through her work at the University of Pennsylvania. She also was at American University, NYU, Washington, D.C. VA Medical Center, Greenbelt Cares. Good Lord, this is a working lady. She has all kind of experience. Her research is focused on mechanism in mood disorders, psychotherapy processes, and the outcomes research, as well as the dissemination and implementation of evidence-based practices. So I think that's very important to know, that you have such a broad background in all of those disorders, therapies, and it's evidence-based, because we don't want to just practice on y'all tonight. These are very, very qualified people. So I also want to introduce Dr. Jamell White. She is a staff clinician for the Neuroscience and Novel Therapeutics Unit. And this department is the Emotion and Development Branch at the National Institute of Mental Health. Dr. White has received her PhD from the University of Maryland in Human Development and Quantitative Methodology. Goodness, you guys were studying the books. Like, aren't we glad that there's people out there that love this kind of stuff, y'all? So what else? You have a master's degree in social work from the Catholic University of America, special education from Johns Hopkins University. These are very schooled people, y'all. Thank you guys for coming today. We are really excited, especially in light of some of what we were talking about earlier before we got on this talk, is about what are the signs and symptoms that we need more help when our young people are irritable, when they're distressed. So this is such a timely topic. And I stopped sharing screen because I know you're
okay. Yes. All right. So as we get our slides up, there we go. I just want to say that Dr. Herman and I, we are just very excited to be here this evening, to be able to talk with you about severe irritability and anxiety in youth.
Can you see my slides?
I don't see anything advancing yet, and we can see
not
the,
yet.
Okay.
It was on, but now it's off. I mean, I guess you stopped sharing. And everyone, I forgot to tell you, just please put your comments, your questions in the chat. If you use the Q&A, that is fine as well. Everyone is muted right now, but you'll be able to ask questions in the chat, and we'll be putting resource links in the chat as well. Oh no, it was just working. Do you want to send it to me?
Yeah, let me send it to you. It seems to
Let
be
me exit out of it.
frozen. So I apologize. All right, I'm going to send it to you. Give me 1 second.
So someone was saying that they could see it, just not the full screen. Yeah.
Hold on, I'm trying to pull up my mail now. Sorry, guys. I need to have my music cued for times like this.
No problem. We will go with the flow. We will
My
go with the
lo-fi
flow.
beats. All right, hold on.
Try it again. I force quit the program because it was freezing. So I'm just going to share it again. Just bear with
Okay,
me 1 second.
awesome.
Can't miss those technical difficulties. Here we go. I'm going to Larger.
Perfect. So we can see, there we
Yes,
go.
now it's
Perfect.
that. Yep.
Perfect.
Ah,
Perfect.
never a dull moment. Welcome. All right, I will move
Right.
forward.
Perfect. So the information that we're going to discuss has been supported by the NIMH Intramural Research Program, and there are no conflicts of interest for us to disclose. All right, so we are going to talk about tonight. We've got a lot that we hope to cover. So we hope to be able to talk about how does anxiety relate to the brain. We want to also talk a little bit about the prevalence and risk factors of anxiety in children and youth, and how anxiety disorders and school refusal are related. We want to talk about that. We're also going to hit on some treatment strategies for anxiety in youth. And then we're going to shift the focus a little bit to irritability. We're going to talk about what is irritability, why is it important to study irritability, and we're going to talk about a new treatment for irritability as well. All right, so we're going to start with anxiety in youth. So just to hit on a little bit of an evolutionary explanation of anxiety, the first thing that I think is important for us to remember is that anxiety in and of itself is not bad, right? It's actually quite adaptive and functional for us. And so when we experience anxiety or fear, for example, it warns us of a potential threat. And the part of the brain that is closely related to fear is the amygdala. And it's the part of the brain that helps us with processing fearful and threatening stimuli. So kind of like that snake that you see in that picture. And so because of anxiety or fear, when we see something that could be a threat, like I said, like that snake, our brain signals us to be careful and to possibly flee. So that would be that fight or flight reaction. Good, beautiful. So as I mentioned, anxiety in of itself is very, functional. So is fear, and it's also developmentally appropriate as well. So one way that it's functional is that it helps us to make good decisions. So we stay safe by being careful, right? And so when we have anxiety, we tend to overestimate the threat or the danger, and we tend to underestimate our ability to handle or manage that threat. And we're going to talk more about this in a moment, but we tend to think of anxiety as having like three aspects, which we call the tripartite model. So that would include the cognitive or thought response. It would include the behavioral response. And then it also includes the physiological or the body or physical response. So just a little bit about the prevalence of anxiety. And so here we know a lot of different things. So first, we want to mention that anxiety is the most common mental health issue for children. And about 1 in 5 kids has anxiety. And so one way to think about this is that in a classroom setting, 4 to 6 out of every 30 kids will have significant anxiety. So that's pretty big. And so we also know that anxiety, along with other behavioral and emotional problems, can be seen in early childhood, as early as preschool even. And so research tells us that there are genetic and environmental influences on anxiety. So for example, children of parents with anxiety are 6 to 7 times more likely to have anxiety. And an example of an environmental factor might be childhood experiences or social situations, or even life stressors, for example. So here is a breakdown of various risk factors that can contribute to anxiety. It might be family history, child temperament, modeling, some stressors or traumatic life events, and parent socialization, for example. And just to kind of hit on a couple of them, if we think about family history, here we're really looking at some genetic factors. So parents or family members with anxiety or depression, a child who is in a family that has a history of anxiety or depression, they may be at higher risk for developing anxiety, for example. If we think about child temperament, Here, you know, if we have kids who are prone to emotional lability or kind of, you know, kind of having like highs and lows and rapid kind of mood swings, so to speak, they may be prone to anxiety. Or kids who have anger, irritability, they may be highly inhibited children, or they are more self-conscious or restraint, right? Or they may have kind of wariness or be overly cautious. These kids, their temperament, they may be prone to anxiety. If we're thinking about stressors or traumatic life events, here we're, you know, if there's a death in the family, if there was an accident, an unexpected event, academic stress, separation or anxiety in the family, those types of things are contributing factors to anxiety many times. So it is important for us to mention that there are symptoms or characteristics of anxiety that may mimic or match more than one diagnosis. So for example, attention deficit hyperactivity disorder. So the daydreaming or the avoidance that we might see often look like anxiety. And there's also a lot of comorbidity, or meaning kids who might have ADHD, for example, may also have anxiety oftentimes. Autism spectrum disorder is another example of a diagnosis where there's a high comorbidity or a high chance that there is the autism and the anxiety there. It's not uncommon for a child with autism to possibly also have anxiety. Medical conditions is another example. The child has diabetes or asthma, sleep disorders, anxiety disorders. And I just wanted to say here for just a second that even within some specific anxiety disorders like generalized anxiety or obsessive compulsive disorder, some of those symptoms, even within specific anxieties disorders, might look very similar. And so it's important for us to just really make sure that we are gathering as much information as possible so we can make the accurate diagnosis there. So just to reiterate again, that anxiety in of itself is not a bad thing, but we do need to know when it becomes a problem. So like in other words, when to worry that it's excessive worry. So some examples of signs of concern might be if the child is easily distressed or agitated when in a stressful situation, or if the child tends to ask repetitive reassurance questions. You know, a lot of those, what if this happens? What if that happens? They're inconsolable, or they don't respond well to logical arguments. If the child has a lot of or complains a lot of headaches and stomach aches, or they're regularly too sick to go to school, those are some other signs. If they have this, what we call anticipatory anxiety, so they're worrying about something that hasn't yet happened, and they're worrying about it, you know, days, weeks, hours ahead of time. So way in advance sometimes, they're worrying about something that hasn't happened. If we're seeing disruptions in their sleep, so they're having difficulty falling asleep, or they're complaining of frequent nightmares, or they're having fears about sleeping alone. They're not able to sleep alone. They want you to sleep with them or put them to bed and stay with them until they fall asleep, and that sort of thing. Perfectionism is another example of when it becomes something that we want to keep an eye on. If a child is highly self-critical of themselves, I can't do anything right, I'm the worst, you know, that kind of thing. Or they have very high standards that make them feel like nothing is good enough, or they're not good enough. They might even do something over and over again just to get it just right. Overly responsive kids, these are people-pleasing kids as well. So they want to do everything that they can so that they don't upset anyone, and they do everything just exactly right in the way you want them to do it, or they think you want them to do it. There's an excessive concern many times that others are upset with them. And they engage in a lot of unnecessary apologizing, even for things that were completely outside of their control. They might demonstrate excessive avoidance. So they might refuse to participate in activities that you have been talking about for a while. They might refuse to go to school. They might refuse to participate in an enjoyable activity even that they've loved in the past, but now let's say there are new people there at this time that they don't know. You might also see some disruption in the child or family functioning. So again, difficulty with going to school, They're not wanting to go over to friends' houses, or the kids might always have to come over to their house instead. They might not want to do a sleepover to someone's house, or play dates are difficult. And then you also find that there may be excessive time spent consoling the child, or a lot of that coaxing of that child to do something, even normal activities like homework and hygiene and going to school and such. So what do anxious kids look like? So here are some behaviors that you might see the child showing. So the child might cry a lot. They might be very clingy. So they might want to know where you are, or they might text you constantly if you just leave the house for a short period of time. And even if there are other family members in the home with them, but they're constantly texting you, where are you? When are you coming home? Is everything okay? You know, that sort of thing. They might be very fidgety, or they might even be very irritable and aggressive sometimes, especially when they're experiencing that anxiety. Some of the avoidance behaviors you might see, keep mentioning this refusing to go to school, or this is also a common one, complaining a lot of physical symptoms. So a lot of headaches and tummy aches, just general aches in their bodies that are kind of unexplainable by other conditions or what have you. Refusing to go somewhere alone, even if it's just like to go across the street, someplace that, you can actually be in their sight, but refusing to do those kinds of things. Procrastinating. Engaging in a lot of reassurance seeking. So they'll probably be asking a lot of questions like, is it going to be okay? Are you sure that this isn't going to happen? Are you sure that's not going to happen? Am I going to be okay? Can I really do that? So these are some of the things that we might be seeing and hearing from kids who are highly anxious. So thinking about, when does anxiety become a disorder? Well, it becomes a disorder when there is an interference in daily life, where we will see a lot of avoidance, that distress, and when it's persistent versus transient, or it's constantly happening versus just kind of coming and going. And so, gotta love anxiety girl over there, right? So what it says, able to jump to the worst conclusion in a single bound. That's a great visualization and representation of what anxiety would often look like.
So now that we've talked a little bit about what you should be looking for in terms of if you have any concerns regarding children and their level of anxiety, we talked a little bit about anxiety girl, as well as when does it become a disorder. So now we want to talk about different types of anxiety disorders, right? Not all anxiety is created equal. I bolded here the ones that we're going to be discussing today, and then the other ones are just for you to be aware that those exist. Obviously, some of you might be already, but mostly we're going to focus on separation anxiety, generalized anxiety disorder, social anxiety, specific phobias, and of course, panic disorder and selective mutism are also forms of anxiety. So we want to talking a little bit about separation anxiety disorder. So this is what one would need in order to diagnose someone with separation anxiety disorder. So essentially, the bullets here are all the possible symptoms. And then in order for somebody to be diagnosed with separation anxiety, they would need 3 of these symptoms. So basically what really the gist of separation anxiety is developmentally inappropriate and excessive anxiety about separation from a caregiver. So some of the things you're seeing here, right, are recurrent distress upon separation or anticipation. If you see the girl here, I copied this from the New York Times. There was an image on it and there was an article about it, right? She's crying, the mommy's leaving at the house and she won't let go. One thing to think about is that, of course, the age of the child. Obviously, if the child is younger than 4, usually we don't see that as a disorder, right? Because it's developmentally appropriate to be nervous or anxious when the caregiver is leaving. But once they start to hit the age of 5 and older, when they start going to school regularly in this way, it would be signs of a concern, if a lot of these things are present, right? So persistent worry that something bad's going to happen, more so than what would be normal. What was worrying about kidnapping or somebody getting into the house. I mean, these are things that I remember kids sharing with me, when they come in for an evaluation, let's say, sometimes I had a kid who wouldn't nap because he was afraid of getting kidnapped. So that to me is, right, cause for concern. If you think about the slide we were presenting about interference and avoidance, right, you're thinking about distress. This is a child that gets very distressed so much so that they don't nap because they're worried that they'll get kidnapped or a parent will get kidnapped, right? So then I start to think a little bit about, does this meet a threshold for a disorder? That's a worry about separation that seems excessive, so much so that it's getting in the way of this child, right, doing something that most of us would love to do, which is napping, right? So refusing to go to school because they don't want to be away from the caregiver because they have an excessive fear of something bad happening to them or the caregiver, right? Refusing to go to sleep without attachment figures. I do want to point out, in some cultures and in some families, it is completely sort of their norm and a value to sleep with children and for children to sleep together with parents or caregivers. So I just want to, that's something that we also want to make sure when we're assessing that we're not pathologizing or calling things disordered that is not, because, it depends on the family, parents do co-sleep. So, but if it's not something that the family holds value to, or it's expected, like the other siblings are able to, and at their age, we're able to, let's say, and the child can continuously is unable to stay in their own bed or in their own room, you might want to start thinking about, is this something that could be problematic for this kiddo? And then complain of physical symptoms when anticipating separation. So similar to what Dr. White was sharing about unexplained somatic complaints, unexplained stomach aches, feeling nauseous, having headaches. Usually, let's see, does it have a pattern? Is it around the time when they have to go to school? Is it different on the weekends? They're fine because they're with you all the time. So these are the types of things you want to be thinking about. A little bit more about separation anxiety here. Fears of harm to either themselves or the family, as I shared. Desire to be home with parents to make sure nothing happens to them. And in some ways, separation anxiety is a little tricky because as parents or caregivers, right, it's endearing sometimes that children care so much and that they worry. And of course, we want that snuggle time. So, some of the parents are kind of overlook the fact that the child's sleeping with them in their bed because, it feels nice. Well, they're only young, but for so long, and then they won't want to. So it's interesting, right? That it complicates it a little bit in terms of seeing this as something that might be getting in the way for the child. Sometimes they have nightmares that have themes of monsters or illness or natural disaster, driving safety, fear of death. Sometimes I hear, right? Because it has to do with the separation from family. That seems a little bit inappropriate or above what one would expect for a child of that age or where they are developmentally. And then of course, make sure for us, we have to always be mindful about if there is a family. So recently I was evaluating a kid whose grandparent passed away maybe a month ago or so. So they were showing signs of separation anxiety, but I would never diagnose that then because it makes sense that the child would be more worried about the caregiver being present and worried about the safety of people around them and themselves, given the context under which this is happening. So being mindful and careful about traumas, obviously, and then family illness as well. So identifying separation anxiety in children. So what common reassurance behaviors may you see from kids in school who have separation anxiety? Lots of questions, right? Clinging, holding on to the caregiver, preference to be home, finding reasons and excuses to be home, going to the nurse's office, saying that they're sick. You get a lot of calls, you got to pick up your kiddo. You start to wonder like, is this more than I would expect for most kids? Is this getting in the way? Are they missing school, right? They're missing school, which means they're missing socialization. They're missing interacting with other kids and thriving in this environment because they want to be at home because they have this excessive worry or fear about the safety of themselves or others. And in terms of treatment, it's important to treat what we call like reassurance seeking. So, what we're trying to say here is basically, is it going to be okay? Am I going to be okay? Is it okay that, are you going to be okay? I remember a parent having to reassure the child that they would go and like actually check windows and they would try to help the child see that there's no safety concern, but then in a way, this is sort of feeding that anxiety a little bit, right? It's the child is seeking reassurance and the parent is providing the reassurance. The thing about anxiety and reassurance is that it doesn't really work because it maintains the anxiety. And then the child engages in what we're calling safety behaviors. And the safety behaviors could be, doing certain things that would make them feel safe so that they feel like they're not separating for the parent. And then we're going to be talking a little bit about exposures later as a form of treatment for anxiety disorders. And we'll introduce you to a new treatment that also uses exposures for irritability. So generalized anxiety disorder, well, you know, if you separate those words out, it kind of, it makes sense. It's like anxiety about many things. So it's more general as opposed to specific, where separation was about the caregiver and themselves and the separation piece. This is more about like worries about a lot of different things, right? So excessive worry and anxiety that occurs more days than not. One key feature, if you notice the italicized, controlling the worry, like having difficulty controlling, you know, if I ask a kid, can you get rid of the worries? And they say yes, then that would not be a disorder, right? But if you can't stop the worrying, if it comes into your head and it gets in the way, because what does it get in the way? Because it causes some of this, right? Maybe it makes the child restless. Maybe they feel fatigued. Maybe they can't concentrate because they're worrying about, you know, different things. You know, I had one kid that was worrying about how he was going to pay for college and how the mortgage was going to get paid. And he was like 8 years old. And I'm like, what? So it would give me pause, right? To be like, oh, and these worries would keep him up at night or make him really angry, right? When he was worried and anxious. So irritability, muscle tension, sleep disturbances. So these are some of the signs and symptoms that would be critical in order to diagnose someone with generalized anxiety. Obviously, it has to cause clinical distress. Distress, remember that interference, avoidance, distress, and persistent, right? Those are 4 key factors to determine if something's a disorder. And obviously not due to substances or any medical condition. I know Dr. White mentioned some medical conditions that can mask themselves and look like anxiety, but they're not. So the generalized anxiety, the what if, and this is Mr. Worry over here. Excessively self-conscious, frequently reassuring seeking. We talked about that. Worry about negative consequences. You know, a lot of worries about what they're doing, how they're doing it. Did they replay what they said over and over again? Did I say that right? Oh, I can't believe I said that to Johnny or you know, Mary. I can't believe I did that. And keep playing that out because there's nothing they can do, but they still worry about it and whether they did it right. Constantly asking if what they're doing is okay. Worrying about negative consequences, you know, worried about what's going to happen in the future, worried about finances, worried about their school performance, worried about their game, even though they might be a straight A student, right? These are the kinds of things we want to be thinking about. Overly perfectionistic, what was mentioned earlier, right? Excessively critical of themselves, or like, yeah, I mean, I still got like 3 wrongs though, but you got a 97. Yeah, but I didn't get 100. So persistent concern about the performance. And again, those somatic complaints, you know, the gut is really a big indicator if there's something's going on. If it's not, obviously, if there's not a medical reason why that's happening, the headaches, obviously needing to use the restroom a lot, sweating, shaking. So these are just signs of some anxiety symptoms. So now we're going to move on to a different type of anxiety. So we talked about separation, we talked about generalized anxiety. Now we're going to talk a little bit about social anxiety disorder. Social anxiety disorder, again, sounds a little bit like what it is. Excessive fear of social evaluation or embarrassment. We put the picture here, you know, this little guy with his heart kind of shaking, with the eyes staring, right? You know, this kid is kind of looking out and worried about how other people are going to perceive him, how he's going to be, how's he going to interact with them. So worried, you know, it usually is around parties, talking to authority figures or teachers or adults. They may not raise their hand in class because they don't want to talk because they're afraid they're going to say something wrong. Maybe speaking to others in public is worrying to them. You know, he doesn't even know how to start this conversation. You know, it's more common in adolescent. It's different for each kid. So being mindful of that. And this leads to a high rate of school refusal, right? If you're worried about being evaluated, if you're overly worried, right, sort of excessive worry above and beyond of what is required or needed for the situation, you're worried about being embarrassed, it would make sense. Remember, fight or flight. It would make sense. You want to get away from the snake because you're estimating the threat, right? You think, oh, something bad's going to happen. I'm going to be evaluated. I'm going to be embarrassed. So you're not going to go to school because that way you avoid the opportunity of being embarrassed, right? But that's only going to maintain the anxiety. That's the problem, right? So social concerns and anxiety. So social anxiety, 3 to 13% incidence of social anxiety. The most common of the anxiety disorders. You see the kid here freaking out because he has to give a speech at school. Commonly fear situations or performances, social situations. You know, if your kid never orders food, always asks you to do it, right? That's kind of like a safety behavior, asking you to order food, and then you doing it sort of reinforces that. Asking for help or starting or joining a conversation is difficult. Often see diminished social skills, fewer or no friends, maybe isolated, sometimes limited speech because they're worried that they're not using the right words and that they're going to put the words together in a way that's going to make them be judged or evaluated. So it's easier not to talk, right? Because then there's nothing to judge. Similarly with school. If I don't go to school, I don't have the opportunity to be embarrassed or to make a fool of myself. So if I don't go, then I don't have that. I don't have to deal with it, right? Being overly shy, like too shy, like they never get over that initial warm-up period. Trouble raising their hand. So they don't do well in school sometimes because they never participate. In some of these classes, participation is a big part of the grade, right? They might not have a lot of friends because they're avoiding it because they're afraid they're going to say something. So these are the kinds of things you want to be thinking about when it relates to social anxiety. So now we're going to move on to a different type of anxiety. This is specific phobia. So with specific phobia, it's basically a fear of a particular type of stimuli. So in this case, I put a couple of things up here. One of it can be a fear of the thunder or rain or the, bad weather. And another one could be bees, fear of bees that makes kids maybe not even go out because they're afraid they might have bees, but there's no bees around. They're like, no, but there might be one. So I'm not going to go out. And then afraid of the dark, of course, with everything, I just want to make sure that it's clear that there's a certain age where a lot of fears and a lot of anxieties are very normal, depending on the developmental age and where they are. So, fear of the dark as they get older to the point where they're not able to do certain things where it's getting in the way. That's something you want to be thinking about. So marked or persistent fear for at least 6 months or more that is excessive and unreasonable, in the presence or anticipation of specific situation or object. I described the ones in the pictures already. Out of proportion to the actual danger in the situation, right? There's no bee out there. Oh, but there could be, so I don't want to go. I had a kid who wouldn't throw out the garbage because it was nighttime and they were afraid something bad would happen. So they were afraid of the dark. So their chore was to take out the trash and they never would do it because they were so fearful of being out in the dark. So again, storms, needles, right? You have to hold them down or they cry hysterically or you can't tell them, things like that. Fear of vomiting, that's a common phobia as well. Costume characters, spiders, bugs, dogs, bridges. So these are some common specific phobias. And school refusal, right? So school refusal in and of itself is not an anxiety disorder, but it is something that can be seen with various types of anxiety disorders. So not a diagnosis, but a cluster of problematic behaviors is what we're calling them. So chronic, complete refusal to go to school, difficulties in school for an entire day, in terms of not being able to attend classes or staying in the classes, right? They will go to school, but then they end up at the nurse's office or at the counselor, and then they're trying to kind of get you to come back and get them. So it's important to determine at what point the school should label the behavior and be treated as school refusal behavior, right? So thinking about how much school are they really missing? How much school are they not attending? Is it school refusal? Obviously with school refusal, it's not an anxiety disorder, but it is a symptom of a problem. So the question is, what could be the underlying problem for the school refusal, right? One thing to consider is anxiety, right? If they have separation anxiety, they might be refusing to go to school. If they have social anxiety, they might be refusing to go to school. If they have a phobia, maybe there's something at school that is the thing that they're phobic about. So therefore they might be refusing to go to school. Right? There's depression as well. There might be many reasons why kids may not want to attend school. Maybe some behavioral issues. Maybe they have learning difficulties, right? Maybe it's not anything to do with social anxiety. Maybe they just really have a hard time and they haven't been diagnosed or been tested. So they might have some difficulties learning, or they're being bullied, which, I think all of us are aware of how tragic and horrible that can be, and why someone who's being bullied, right? Why would I want to go to school? So these are some of the things you want to consider if you're seeing some school refusal. Of course, like I said, rule out learning disability that can lead to frustration, poor performance, low self-esteem. So always important to get kids tested if you think that might be the root cause of why your child might not be wanting to attend school. And then obviously, one of the things about refusing to go to school, where if they're not in school, where are they? Well, they're home, and what are they doing at home? So I had one kid who would sometimes not go to school, but then at home he would get to play video games. He would get to spend the whole day watching YouTube. He would eat whatever he wanted. So, I mean, it's like, I guess it is better to stay home too. So thinking about what are the secondary gains? What is the child getting from staying at home?
All right, so now we're going to get into the treatment of anxiety. And so you may remember that I mentioned something called that tripartite model earlier, which involved the cognitive, the behavioral, and the physiological response to anxiety. Well, this cognitive triangle shows the connection between our thoughts, our feelings, and behaviors in response to anxiety. And so with this visual, we can see that our thoughts influence the way that we feel, which in turn has an impact on our actions or our behaviors, which then affect our thoughts. And the cycle continues, right? And we can see with the bidirectional arrows, the arrows pointing in both directions, that the direction of influence can go either way. And oftentimes this pattern, especially if it's like this negative thoughts kind of pattern, it's hard to break this without intervention. So let's take a look at how this plays out using this social anxiety example. So a child might have a thought that is, what if no one talks to me? No one likes me. Everyone's gonna laugh at me. What if I mess up? So these are the thoughts that this child is having. So in turn, the feeling or the physiological response that the child might have would be an increase in heart rate, sweating, shaky, stomach aches, headaches, right? So this is now this pattern that's starting. And then in response to those physiological responses and those thoughts, the behavior that we might see is this child fleeing, right? So avoiding social situations, the school refusal that we keep talking about, freezing in social situations, right? Not knowing what to say, not knowing what to do, perhaps showing poor eye contact. And maybe they just say, forget it, and they just completely isolate. So they refuse to do, they refuse to spend time with friends. They're not doing extracurricular activities. They're just isolating themselves. So that's an example of how that might play out. So CBT, or cognitive behavioral treatment, is the evidence-based, so we talked about evidence-based treatment, right? So the evidence-based treatment for anxiety, and it involves psychoeducation, or the teaching about anxiety and providing information and support so that the child can better understand and cope with their anxiety. That's the psychoeducation piece. Somatic management skills training. So that might be techniques of breathing retraining or breathing exercises, or becoming more aware of their physiological responses. Sometimes that might involve movement as well, right? So kind of the relationship between the mind, body, and brain to some degree. And then there's this cognitive awareness and restructuring. So this is helping the child to be aware of their thoughts. In this case with anxiety, they're often negative thoughts, right? And being able to change the way that we think. And then exposure methods. Dr. Herman talked about that a second ago. And with exposure, we are exposing or having the child be in uncomfortable situations slowly and carefully in order to help them learn to tolerate the discomfort that they're feeling. And then relapse prevention is the other portion of the treatment, in which we are trying to reduce or prevent the return of old ways of thinking and behaving when they're anxious. We don't want the child to go back to old ways. We want them to maintain the skills that they learned during the treatment that they were in. So what should happen first, right? What do we want to do? So again, first and foremost, we want to make sure that we educate the child and normalize the anxiety. We want the child to know that they are not the only one who experiences these feelings. Remember, everyone experiences anxiety sometimes. It is adaptive and functional, right? It can be adaptive and functional. And it's not uncommon for kids to have, poor or very limited insight into this. So again, they might think that they're the only one who has anxiety, that we know that this isn't true, but they may feel this way. Before they begin to understand the anxiety and understand the signs and such, they may not be aware of what's happening inside of their body. Okay, so that's part of that insight that we are trying to help them to develop. And we also just want to make sure that it is important to be able to identify a CBT provider for an assessment. And here we have provided some resources for finding that CBT provider. So then moving on to some of those physiological or body responses that we might see. And these are some of the things that we want the child to become more aware of and know that this is happening in their bodies. So again, those tummy aches and those headaches, the nausea, frequent trips to the bathroom. So this might be like they really do have to go. And sometimes they might be using that, I need to go to the bathroom, to avoid a situation. Tightness or pain in the chest, sweating, dizziness or lightheadedness, the heart racing, and many, many, many more symptoms that the child might be experiencing. So now we want to talk a little bit about these cognitive distortions or thinking errors, some people might call it, that happen oftentimes. And some of these things that we might see, some of those cognitive distortions are kids thinking or assuming that bad things are going to happen. I just know something bad's going to happen. Nope, can't convince me otherwise. Something bad's definitely going to happen. Or biased attention, their attention is very much focused on the threatening words or the criticism that they hear. They might not even remember all the positive feedback that they might have heard, but they're highly focused in on those threatening words and criticism. They might interpret ambiguous or kind of neutral situations as being more threatening. They might engage in more negative self-talk. Again, I'm the worst, I'm horrible, I can't do anything right, I'm gonna mess up, oh, I said that wrong. These are examples of negative self-talk. They might underestimate their strengths or assume that they can't handle stressful situations. And they might engage in what we call catastrophic thinking, or assuming the worst is going to happen. It's kind of like that ball that begins to roll down the hill and it gets bigger and bigger and bigger. And so in treatment, the focus is really trying to help the child to identify more helpful ways of thinking by challenging those unhelpful thoughts and coming up with more positive thoughts. So in thinking of some of the tools that we might be helping the child to learn, we call this kind of cognitive reframing, right? And so we might teach the child some of these ways to change their thoughts. So if the child is having some anxious thoughts, such as I'm in danger, or everyone is mean to me, no one likes me, or I can't cope, things never go my way. These are common examples of anxious thoughts that kids might have. We want to teach them to be able to reframe or have an alternate way of thinking about the situation. So examples of non-anxious thoughts would include, I am resilient and strong. Most people are nice to me. So it's not negating that there is the possibility that someone might not like them, but most people like me. Kind of like, what's the evidence for no one likes you? I can think of a couple people who do, right? Or I might not like doing it, but I can handle it. That's very different than I can't cope. I might not like doing it, but I can handle it. And then in replace of the things never go my way, we can teach the child to maybe think of, generally, things will work out okay. So that's an example of how we teach kids to reframe those anxious thoughts into more realistic or non-anxious thoughts. So then moving on to exposures. And exposures are the behavioral part of CBT. Okay, that's the exposure work. And as I mentioned earlier, that's about teaching kids to face their fears. And research suggests that the brain learns new associations between unconditioned stimuli and the conditioned response. So an unconditioned stimuli is a stimulus, right? Often a neutral situation that can lead to an automatic response or an unconditioned response. So if we think about like Pavlov's dogs, that might be a good way to think about it. The food was the unconditioned stimulus and the conditioned response was the salivating, right? So therefore we learned that through exposures, the brain learns new associations between the stimulus or the anxiety trigger and the way in which the child learns to respond to that trigger. So just to give a quick snapshot of how exposures work, we would help the child to develop what we call an anxiety hierarchy or ladder. And they develop a list of situations that are anxiety provoking, going from easy or less disturbing to hard, most disturbing. And the idea is that they work their way through this ladder in the CBT treatment. And again, we want to be realistic and we want to start very slowly, because you don't want to start with the most anxiety triggering situations, because we want the child to experience some early success so they will keep trying. So that's really important. And as the child learns to manage through the lower rung situations, then they can move up to the more difficult situations. And of course, rewards must be a part of this process. And that's, again, part of why we want to start slowly with the easier situations first and working our way up. Because as the child masters the different steps, we want to make sure that they get rewarded. Verbal praise and all of these kinds of things. We also want the kids to learn how to reward themselves, right? What do they want to give themselves as a reward as they build up their skills? They get skilled up and they're learning to manage and cope through their anxiety. We all, respond well to motivation, right? And rewards. So here's an example of that fear hierarchy. So Dr. Herman mentioned, the fear of vomit is a common example. And so here, the child and the therapist likely developed this list of tasks connected to vomit or vomiting, right? So kind of starting at the bottom and working our way up, we see that the tasks become more involved or directly connected to vomit, of all things. So we see her listening to people talk about vomit. So that, is like at a 3. And then we move up to writing a story about a character vomiting. Then we move up to imagining myself vomiting. So just picturing that in my head. Now we're moving up to listening to vomit sounds. So it becomes a little bit more real. Then we are eating, and then we immediately start running around and doing activity, because if your food hasn't had a chance to digest fully, it may start to increase some of those physical symptoms of like, oh my gosh, I'm not gonna be able to keep this down. Okay, so just having the child be able to feel that level of distress. Then watching a silent video of a child vomiting. So you don't hear the sound, but you're watching this happen. And now you're beginning to watch videos of the child vomit with the sound. Now you're watching videos of adults vomiting with the sound. Now you're staying in the classroom when a peer vomits. So this is all getting really real here. And now, like, finally, the final step is actually touching the vomit. Okay, so we can see how it gets harder and harder and harder and harder and harder. What is important to also mention is that the child would be the one responsible for rating the level of distress connected to each task, because it's going to be different for each person. What's a 7 for that child might only be a 4 for someone else, right? And so again, with an exposure, you start with the low distress items first, and then slowly work your way up. And so as teachers or caregivers or parents, we definitely might find ourselves getting frustrated with the child's anxiety because it is persistent and it interferes with their life. But we have to remember that these kids are not choosing to be anxious. So we don't want to say things like, I don't know why you worry all the time. You do so well in school, or everything is just going to be fine. There's nothing to be scared about. Why do we have to go through this all the time? We don't want to say these kinds of things because some of these comments are not only unhelpful, but they are also invalidating to the child, right? And the other thing too is we might sometimes find ourselves wanting to eliminate the situations that might cause anxiety for the child. So we might want to overprotect or overly accommodate the child. And while this might help temporarily in that moment, it doesn't help in the long term for the child's coping abilities. So we want to recognize that learning to change our own behavior as the adult can help make a significant difference in the child's behavior. So some helpful things that we might say in changing our behaviors as adults, we want to also reframe our comments to something more like, I know this feels scary for you, and those feelings are no fun. So I know this is scary. So that's validating the child's feelings. And these feelings are not fun, right? So a double underscore validating. Remember, this is just your anxiety or fear talking. So it's acknowledging that this is happening, that this is real for the child, but also going back to that psychoeducation piece. But remember, that's that fear talking right now. And I know that you can handle this. So this is showing that you have faith in that child's ability to cope with this. Because remember, sometimes the kids will underestimate their ability to cope. We want to reinforce that, yes, you can handle this. How did it work out before? So having them think back to what was helpful in the past, or right now you're worrying that this is definitely going to happen, that catastrophic thinking. But can they think back to, well, did that happen before? Did that happen last time? Oh, that might have just been that anxiety talk, right? Or what do you think may happen? And how would you handle it if it does happen? So this is kind of helping the child to cope ahead. So if it does happen, how are you going to handle this? And how likely do you think this is going to happen? So these are ways for us as adults to be able to reframe the comments that we have. And so in the next few slides, I think we're going to review some parent or adult strategies that are often helpful, but some of the things to highlight would be to encourage your child to face their fears and not to run away, right? Because that's the instinctual thing to do, is to run and avoid and, I'm not going to deal with it, but then they're not learning how to navigate through that distress. To tell their child that it's okay to be imperfect. And in fact, we might even encourage them to be imperfect on purpose, to see that life does not end just because they might have made a small mistake, right? That they will get past that situation. We want to help them to focus on the positives, because it's so easy for them to concentrate highly on those negatives, that bias that we were talking about, right? To schedule relaxing activities. Just as you would in their social, so some social support, some sports, some school engagements. So just to allow them to have activities where they are seeing success and enjoyment. We want to model behavior. We want to model approach behavior. We want to help them to see that I don't have to avoid this situation and I can still live through this. To help them practice self-care and positive thinking. We want to teach them to reward their brave behaviors. I remember I worked with a kid and we wrote a brave song, actually. We came up with lyrics and music and all of this, right? This was their way to reward their brave behaviors. We want to encourage good sleep hygiene. That's also really important as well. We all know if you don't get a good night's sleep, it's hard to be able to manage through the daily life, right? And we also want to create a safe environment where the child feels comfortable expressing their anxiety. That's so important. We want to make sure that the kid feels validated, not invalidated, that their experience is validated and that they can cope and manage through that. So in thinking back to the point of over-involvement and accommodating, again, we want to acknowledge that anxiety may cause children to feel that they are more in need of their parents, right? And with accommodations, for example, with an anxious child, the parent might be unable to go out as much, or they might have that child following them around the house. And of course, this can interfere with their personal boundaries, the parents or their family's personal boundaries. So what we want to do is to help create those healthier boundaries and increase that child's independence and feelings of self-efficacy. So just again, to review some examples of what over-involvement might look like, it would be allowing the child to avoid school. Okay, you don't have to go to school today, no worries. Or, okay, you don't want to go to your, first and second period. Don't worry about it. We don't have to go to school until fourth period. So allowing the child to avoid school. Or you as the parent calling out from work to stay with the child. Okay, that's another example of over-involvement. Or staying with the child all throughout the day and night and not encouraging separation. So instead of possibly saying, okay, so I'm gonna sit here, I'm gonna watch you walk in, I'm gonna watch you walk into the school building, and I'll stay here for 5 minutes, right? But not saying, okay, I'm gonna come into the school and I'm gonna sit in the classroom next to you all day long, right? So that's an example of not staying with the child all throughout the day. I'm gonna stay here for 5 minutes, and then I'm gonna go. It's because we want them to be able to see that they can do this. And then again, this might be a slow process. That might be part of the exposure for the child, perhaps. Other examples of over-involvement might be sleeping in the child's room. Again, going back to Dr. Hederman's point about, we also have to think about the cultural relevance of this. Assuming that this is not a cultural norm for this family, sleeping in the child's room and allowing them to sleep in your bed. That's an example of over-involvement. We're feeding into this anxiety monster, so to speak. Or engaging in their anxious rituals. So if the child has a need for checking things, making sure things were locked and things were turned off, and there's nothing under the bed, but they're 12 and 13 and 14 needing you to look under the bed. They're not 3 or 4, right? Or overly rigid bedtimes, but we as the adult or the parent, we are engaging in it. We're accommodating the child. That's an example of this over-involvement. So we were talking a lot about, school. So we wanted to just take a moment to talk about managing anxiety in the school setting. And so we want to say that you definitely want to be the do's and don'ts. So the do's would be to be sensitive, to educate. That goes back to that psychoeducation piece, right? Help the child to learn more about anxiety so they can understand what's happening. And again, just to go back to some of those statistics we talked about at the very beginning, this is very common. So even educating, the larger classroom about anxiety will probably help more kids than we think, right? Giving positive feedback. So helping their attempts to use or praising their attempts to use strategies to cope with the anxiety. We want to be consistent. We want to help them to face their fears slowly. And again, we want to know when we need to seek additional resources. What we don't want to do is to accommodate the anxiety too much. We've talked about that. We don't want to let the child avoid. We definitely do not want to single out that child, okay? We don't want to do that. We don't want to provide excessive reassurance. We don't want to feed that anxiety monster. They're seeking that reassurance, and if we feed into it, we're giving them what they want, and that anxiety monster gets bigger and bigger and bigger. We don't want to be too directive. We don't want to take over because we want the child to learn strategies for coping. And we don't want to over control the child either. That kind of goes hand in hand with being too directive. They need to learn how to manage their anxiety. And we don't want to criticize the child because that, again, it invalidates their experience, and it often increases that avoidance and isolation when we do that. And so here we just have some resources available that you might find helpful, and we've included both book and internet resources here. And then we wanted to just highlight the fact that we do have an anxiety study at the NIMH, and we are always recruiting. Information about the study is on the slide. I will just highlight that we are seeking kids that are between 8 to 17 years of age. There are some other criteria that you see there. And if they do participate in the treatment, it's about a 12-week, it is 12-week treatment. And if you are interested, in case you can't see that number on the slide, it is 301-827-1340. Now we're going to move to irritability.
I'm looking at the time. So we're going to try, I'm going to see how quickly I can move this while also making it comprehensible. All right.
Yes, and also if people can put their questions in the chat so that way we can, we'll have them when you're done.
Beautiful.
Dr. Hederman.
Thank you. Thank you. All right, so I'm not going to cheat you and skimp you with not telling you about irritability. I know some of you are here probably for that exclusively. So we'll talk a little bit about irritability. Essentially, we're going to talk about irritability is the most common reason that children present to healthcare, partly, right, because having an irritable kid is a pain, and right, you want to get them treatment because this is an issue that affects the whole family usually, and a lot of the times the irritability is mostly seen in the home, and it gets in the way of the family life. We're currently developing interventions for this new diagnosis that came out in the DSM-5, which is called disruptive mood dysregulation disorder. That's a mouthful. So essentially, I'm going to go over what the criteria for that is, similar to the disorders that I just kind of walked you through in the anxiety section. And then because of this diagnosis, because irritability is so problematic, and it's one of the main reasons why children present to seek out healthcare, we want to address this pressing public health issue. So we will present on what are the clinical symptoms of what we're calling DMDD, again, disruptive mood dysregulation disorder. We're going to define severe irritability. We're going to discuss the relationship between irritability and other symptoms such as anxiety and inattention, and present some potential novel treatments that we're developing here at the NIH. So first, I want to talk a little bit about Junior. So here's Junior, Grumpy Junior. He's had temper problems his whole life. He was very disruptive at school and in daycare. So eventually, they got him tested, and then they realized that he had attention deficit hyperactivity disorder. However, he was still grouchy all the time and getting into trouble still, and couldn't keep friends, wasn't really invited to many parties, just having a bit of a difficult time. He would argue with teachers if he didn't like what they were saying, or if he didn't want to do the work. Sometimes he would actually have to go to the principal's office. He would just get into a lot of verbal and physical fights. So eventually, over time, he was diagnosed with disruptive mood dysregulation disorder, because they realized that it wasn't just the attention deficit issue that was getting in the way. There was something else. So what is severe irritability? So severe irritability is increased proneness to anger relative to peers. Again, remember, how is it compared to others that are the same age? Proneness means, right, an inclination to, more likely to be angry relative to other people. And we're thinking about it in three particular components. So we're thinking about the frequency. So they're angry more often than most kids their age. They're more easily annoyed than most kids their age. And then their anger stays longer than most kids their age. And this is from a paper from Dr. Brotman, who's the principal investigator of the lab that both Dr. White and I work under, and where we're developing the treatment that we're going to hopefully be able to talk to you today about. So there's two pieces to irritability. When we think about irritability, we think about the behavioral component of behaviors. That's more of that temper outburst, right? It's increased motor activity meaning like moving their hands and their legs, right? That's that punching, that kicking. If you see her mouth, right, that's a motor activity, their mouth going, right? That physical verbal aggression, that's the outburst. That's what we're thinking about. That's the behavioral component of irritability. One key piece is not just the behavioral piece, but then there's the emotional piece. And then if you think about disruptive mood dysregulation disorder, there's the mood component. What's a mood? How do you feel? How does this kid feel 51% of the time? Is this kid angry, irritable most days, nearly every day? Right? It's most of the time persistently angry, chronically irritable. That's the emotional piece of this particular presentation of irritability. So we all know what a temper outburst is. This is from Inside Out, right? She got frustrated. She was trying to get this tower of cards. And then here we go. It didn't work. So she got angry and she yelled and threw everything on the floor, right? So this is the angry character taking over the brain here. So when we think about temper outbursts, we think about different levels. So we start usually with mild. So what we consider mild temper outbursts, right? When we're thinking about that behavioral piece, it's snapping, talking back, mild arguing, name calling. Now when we're thinking about moderate, we're thinking about yelling and screaming. We're thinking about verbal threats like, oh, I'm going to get you. Clenching fists, raising arms to hit, maybe throwing something in anger. They're not trying, usually I hear the remote getting thrown down. They're not trying to break the remote because they like their remote, but they're just so angry that, you know, that motor activity that we talked about. And then what goes into the severe range? Well, now we're talking about, right, harm, danger to others, breaking things on purpose. So using object in a way to harm, breaking things, punching, kicking. That's what we're talking about when we think about a severe temper outburst. Shoving, slapping, pushing, brushing by someone in an aggressive way to like bump them. These are the kinds of things we're thinking about. So what are common triggers? What are common triggers for kids who have the severe irritability? So it's most of the things you would think about, right? The iPad or the screen time, homework, right? Doing homework. Who likes to do boring things? And the best part is going from an iPad to making them do the homework. Now that's a huge trigger. It's going from a preferred activity to a non-preferred activity, right? So that would be a trigger. You know, maybe eating some of their food, right? It's about their expectations. They'd had this plan. They're very rigid sometimes. They had ideas about what was going to happen, and then the unexpected happened and they get angry, right? If they feel slighted in any way, if they feel that, you know, something's unfair, it might be excessive. So if you think about the anxiety, it's that the threat is excessive. In this case, it might be like, there's no danger here. Like, why are you so angry? So some other common triggers that we see, obviously like losing a game can be a trigger. Well, they were expecting pizza all day, and guess what? They came home to this. So then that might lead to a temper outburst. Maybe they're at the store and they see a toy and they want it, and you don't have the money or don't think they should get it. And then they'll throw an outburst, cleaning their rooms. Maybe they have to like share or play with somebody else. That might lead to an outburst, or having to share the TV with a sibling and so forth might lead to an outburst. So that's the behavioral piece that we're talking about, right? That increased motor activity, that expression of anger through your body in that way. And now we're talking a little bit about the mood component, right? So this is grumpy cat, right? It's being grumpy. You know, Krabby Patty is what the nickname for one of the parents they had for their kiddo. So thinking about that chronic irritable mood. So not specific outbursts, but general level of grouchiness or grumpiness. They're grumpy, grouchy, crabby, cranky, moody. These are the words that I hear, right? Irritable is like a very long word, but these are the kinds of things we want to be thinking about. And then how people tend to react. So I always hear, I would say 50 to 60% of the time, the parent feels like they're walking on eggshells to try to avoid the kiddo because they're always so irritable. They have to kind of, it's like double dutch. Like, how am I going to get in there? They got to approach them in the right way, or otherwise they're going to be explosive, right? And then accommodations, right? Sometimes one parent I heard that was made me really sad, they had to go in different cars because the siblings, there's so much fighting, and particularly this kiddo, which is having such a hard time with their temper and their mood that they couldn't be together. So if they would miss out on going out or doing things or going to restaurants because the kid would usually, you know, embarrass the parents, but then they couldn't sort of keep it together. And that's where the dysregulation piece, right? They're dysregulated, emotionally dysregulated. So it's hard for them to kind of, you know, just go through the activity without having an outburst or without having that mood piece get in the way. So why is it important to study this, right? So we're talking about this behavioral component. We're talking about this mood component. Well, you know, obviously the public health impact of these kiddos, particularly irritability, like I said before, is the most common reason that youth are referred for psychiatric evaluation and care. Irritability has been shown to lead to adult impairment. There's a lot of correlational studies and epidemiological studies showing that irritability leads to academic problems, to poverty, to suicidality. So it's really important to study it because it does have these negative outcomes, these negative results later on in life. And then in 2013, the Diagnostics and Statistical Manual of Mental Disorder, which is kind of like our Bible that I use to be able to determine the different types of disorders. And that's where a lot of disorders that I was talking to you about and how I was describing these symptoms and how many you need, it's all listed in this manual. So in 2013, they came out with a new one, which is the 5th version of it. And this disruptive mood dysregulation disorder was added to that. And that's in part from some of the work that our lab has done. So we've done a lot of work on irritability, and it's clear that this is its own thing and it's its own phenomenon. So it's important to study because it's problematic, right? So what is it? What is a DSM-5 say about what disruptive mood dysregulation disorder is. So we talked a little bit about the behavioral piece. So let's talk about what about the behavioral piece? What makes a severe irritability sort of disorder, right? Remember that word disorder that we talked about. So verbal rages or physical aggression toward people or property that is out of proportion or inconsistent with developmental level, right? Are they 4 years old or are they 13-year-old? You know, we had a 16-year-old who then decided to throw let's say tomatoes, because he got really upset and he started to throw the tomatoes that were in the fruit basket across the room, right? Not appropriate to developmental age, given what the stressor was, given what just happened. It has to occur more than 3 times per week. So 3 times or more per week. So that's the temper outburst piece. So you need to have that. Persistently irritable or angry mood on most days. Again, this is a mood disorder. So therefore, it has to be some irritable or angry mood most of the time. They're cranky, they're crabby patty, they're moody, grouchy. Now, it has to be impairing. If you think about the 4 categories for determining whether something's a disorder, it has to be impairing in some way. And in this case, we're going to set the threshold at least in 2 areas, 2 out of the 3 areas, either at home, at school, or with peers. And at least 2 of those areas, it has to be impairing. And it has to start prior to the age of 10. Right? Why? Because we don't want puberty to be a reason why this child is behaving in this way. It could be a hormonal reason. There could be something else going on, and it cannot be made before the age of 6, right? Because we were talking a little bit about 4 and 3-year-olds and how they behave, and we're not going to pathologize normal development, right? Because some kids maybe are a little bit more irritable than others, but it's not a disorder, right? It's not disorder. It's just that they're more than others. It doesn't reach that threshold for it to be a clinical issue or pathological issue. And of course, no hypomania. So it's not bipolar disorder or any of these other types of disorder that where irritability can be present. So speaking of where irritability can be present, so the issue with irritability and why it's important to study is because irritability can be present in a lot of other disorders. If you remember generalized anxiety disorder, one of the signs of generalized anxiety disorder is irritability, right? So in bipolar disorder, irritability can be present. Major depressive disorder, particularly in kids, it doesn't have to be sad or depressed mood. Sometimes it's irritable. Sometimes they're irritable more days than not. And then when you go through the list of the different symptoms, they meet for major depression, and it's not with a sad mood, it's with an irritable mood. ADHD can look a lot like what we just talked about, and we actually study ADHD kids as a control. So we also recruit ADHD kids for our studies to see how they compare with our DMDD kids. Generalized anxiety disorder, separation anxiety disorder, social anxiety disorder, panic disorder, which I didn't talk about, but I just kind of mentioned it. So all these things can have irritability as a symptom or a sign of the disorder. So that's why it's important to make sure you have somebody who's qualified to able to kind of differentiate this. Obviously, we talked about trauma a little bit, but PTSD also has irritability. Oppositional defiant disorder is a different kind of disorder. There's not a mood component to it. It's mostly the kid is angry, oppositional, sort of really blaming others for the mistakes or what's happened. Sort of like a resentful, cranky kid. Conduct disorder as well, that can include, a lot of different other conduct issues. Irritability can be very present in that. And of course, autism spectrum disorder, as we've kind of mentioned before. So, it's really important to study irritability, understand irritability, because it can exist in so many different diagnoses and issues. But we think that disruptive mood dysregulation disorder is a different kind of presentation of irritability that deserves its own studying, and in our case, its own treatment. So I think Dr. White will now kind of talk to you a little bit about that.
All right, so I'll try to do my best to not take up too much time, but want to give it a little bit of justice here. So just to review some of the established child treatment interventions, it tends to focus a lot on behavior management and skills training. So related to behavior management, using principles of like functional behavioral analysis, we're looking at things like the triggers for the child's behavior, what's setting this child off, right? We want to be looking at what the child is communicating through their behavior. And we're also looking at what's maintaining that behavior. Why are they continuing to react the way that they do? There's something that's keeping that going, okay? And so we want to be thinking about rewards and punishment when we're thinking about this as well. Some additional interventions involve the skills training, which tends to focus on teaching healthy and productive coping skills. Similar to what we talked about in anxiety, that involves psychoeducation. So in this case, what is anger? You know, why is anger adaptive? It's connected also to that fight or flight. It protects us from danger, right? We want to be teaching what are our body signals for anger. Then there's that skill development piece where we are helping them learn how to cope with the anger. So how can they self-regulate? How can they express their anger in positive or more productive ways? And some of those strategies that we might be looking at are the breathing exercises, some of those cognitive strategies, teaching some assertiveness skills, like assertive communication versus aggressive communication, right? Those I statements. And again, thinking about what are some okay and not okay or helpful ways to show their anger. So that would be involved in some of that skill development. And so thinking about some of the established parent interventions that we know of, there's this parent management training or coaching and parent stress management as well. And these interventions tend to focus a lot on teaching parents about rewards and punishment. We call that instrumental learning. Teaching parents about setting limits and remaining consistent with their limit setting and their expectations and how they communicate that. We also talk about modeling of the behaviors we want the kids to demonstrate. So if the parents can model that for the kids, right? Because I think I saw in the chat someone saying the kids are always watching and they learn a lot from what we do. So we want to model the behaviors that we want them to demonstrate. And then a big part of what we're doing in the parent management portion of treatment is focusing in on understanding your own emotions as the adult and the reactions that they have to their child's behavior, but also to their own external stressors, right? So they have other things happening in their life. So what are some of the stressors that they might be going through that might be influencing how they're reacting to their child? I can remember working with a parent who was having a lot of work stress and lots of other stressors that had nothing to do with the child, but it was impacting her ability to remain calm and consistent, and her fuse was just really short. So just thinking about, is your cup full or is it empty? That self-care piece of it too. So that's a big part of the parent management and parent training and coaching that we do. And so then there's other interventions that focus a lot on the parent-child relationship and interactions. And here we're focusing in on helping to foster those positive interactions. Again, this includes considering the parent's emotional reserves. Is the cup half empty or half full, right? It involves learning effective communication strategies, and it also involves purposefully setting aside a time aside for positive and pleasant interactions with the child. And so not wanting to rush this at all, but we do have this novel treatment for irritability that we've been talking about at the NIMH. And similar to anxiety, our study is based on CBT, cognitive behavioral therapy, because we know that this is an evidence-based treatment that is effective for the treatment of anxiety. And related to the exposure aspect, like with the kids with anxiety, we are treating this by gradually exposing the child to their triggers, their anger triggers, as opposed to the anxiety triggers like we were talking about earlier, okay? And so we are applying those same exposure principles, but to frustration and helping the child to be able to sit with their frustration and their anger, helping them learn to tolerate the discomfort that they are feeling in that moment. Again, we're doing this with safety in mind first and foremost. And so we are making sure that we have a good understanding of what the child's outbursts look like and how we can safely implement those exposures in a safe way. And so our treatment involves, in the beginning for sure, actually all throughout treatment, that motivation. We're trying to get that child's buy-in. We want to collaboratively work with the child to know, are they ready for this? What's working for you and what's not working for you with your anger? Why might you want to change what's happening, right? What's not working for you? We do a lot of that psychoeducation that we talked about before, helping them understand the connection between their thoughts, their feelings, and their behavior. We're helping them to develop an anger vocabulary, so to speak. We want to make sure that we're using the same language for their irritability, right? So as Dr. Herman said, a lot of kids don't say I'm irritable, right? Or I had a temper outburst, right? They might have said I had a tantrum. I call it hulking out, right? So there's different words we might use. We want to know what language the kids use and the family uses. But the main aspect of our therapy is the exposure. And again, like with the anxiety, we help them to develop a hierarchy of anger triggers, and we gradually help the child work their way up through that hierarchy throughout the treatment. And we use this visualization of the anger thermometer to help the child identify the different levels or situations from low to high. And so we use this language and this visual with the kids. And so in terms of the parent sessions, which are a key component to our treatment as well. We meet with the parents weekly. We give education to them on various modules. A big part of what we are engaging in with the family is that functional analysis of the child's behavior, but also the parent's behavior too, right? So the ABCs, basically, what is the goal of the behavior? What is the outcome of the behavior? What is maintaining that behavior? And we are helping the parents to learn how to reward positive behaviors from the child and to be consistent in their reward contingency and to learn how to actively ignore some of those non-dangerous, irritable behaviors. Okay, so we are going through various modules, learning how to deal with outbursts and setting limits and, providing rewards and again, engaging in those pleasant interactions. And so we just want to make sure that we highlight our principal investigator, Dr. Melissa Brotman, as well as Doctors Ellen Liebenlock, Danny Pine, and Argyris Strangaris. And we want to give a special thanks to our intramural and extramural collaborators, and obviously to our patients and families who have given a lot of time to our research. We want to make sure to thank them. And then our last slide, we want to highlight that we are continuing to recruit families for our study in irritability as well. The number there, in case you can't read it, is 301-496-8381. And so if you're interested or want more information about our studies, please feel free to reach out and contact us. I think we did it. We were able to do it.
You know what? My daughter was sitting back here listening to a lot of the anxiety pieces. And I was like, wow, a lot of this were signs from when she was younger. And even her brother, like you guys had, I was just like, wow, I wish I got this information sooner. So I'm so glad you're able to share it with everyone out here, because I think that can make it so much easier to know that you're not making the situation worse when you're trying to be helpful for your kid. I was one who I did not say the right things. And then if I'm frustrated with them, just stay home, leave me alone. I need to do what I have to do, because it's like you said, if you're going through stressors and, you have this kid it's always something you're like, oh my God, I can't do this again. I have to go to work. I have to do this. So I think this is a great resource for parents. You guys really.
Thank you.
That's awesome, because even some of the you were saying, don't say this, say this. I think that would be a good social media thing for us to follow up with when we're sending out. We're doing a campaign around mental health for our young people. I think that's a great tool for parents to use as well.
Thank you.
So does anyone have any questions? I didn't see any when we were going through, and I dropped your the TTY number from the website and the email for if people are interested in this free study. And with the study, you're getting support and the diagnosis, right? Because you guys are able to go through and see what the root cause is And it may not be ADHD. I think one of the other ones you said was a disruptive disorder. So just to find out what the right diagnosis is can be helpful as well. So Carol Douglas said, thank you for this excellent presentation. Helps me so much in accurately diagnosing my child clients, which I think that's a great resource too. So I'll also, we'll send some people your way just from Cheryl Maxwell, our resource and referral specialist. I'm pretty sure that this will be a go-to, because if we can connect people, that will be great. So we do have a question here. Oh, and Carol had asked, what is the difference between reactive attachment disorder and anxiety?
So I'm gonna have to pull out the DSM on this one, right? So
look, when both of you guys were like,
it's one of those, like, you don't want to really like jump into that. So again, with a lot of these diagnoses, these disorders, so to speak, there may be some overlapping symptoms, right? And so that's why, and like Dr. Herman said, it's like our Bible, so to speak, right? In the community, we do have one like always at our reach. And so when we're trying to differentiate between this or this, it might be, a couple of things that really make the biggest difference. And so that's why we're pausing to answer that, because I don't know if we have one right in our hands to be able to answer that, really, really well. But
and I think that's a good point, that it's so close that you have to even go in and make sure you're diagnosing properly. But you can reach out, Ms. Carol, to the email irritablekids@mail.nih.gov to follow up. We have a couple people that are still on Facebook. Ms. Bazille, thank you for staying on with us. She gave you an applause, a hand applause, because I think a lot of people, I know a lot of times when we're talking about mental health topics, we think it's not a big deal, but sometimes there's so much information we don't know, even though we know a lot, Anastasia Rose said, thank you so much for this presentation. Zakia said, thank you so much. My son was just diagnosed with DMDD, and hearing this information helped me so much. So that's awesome that we were able to give support to someone.
Absolutely. And again, our number's there in case anybody, is interested in the study. And then we talked a little bit about that treatment. So, if you're interested and you want to see if you qualify, call the number. And like you mentioned, we do an evaluation just to see if you qualify as well. There's a couple of steps just to be transparent. It's a lot of steps because we want to be thorough. But we do have that study that we're developing, and we want to see if it works, which is why we're doing it at the NIH. So, if you're interested, if you want to see, try the study. It's 12 weeks. It's 12 sessions. So, we can talk more about that. Obviously, call the number and we can share as much information as you like. We want to make sure you're informed in every way possible if that's something you're interested in.
Yes. Thank you, Dr. Jamell White, and thank you, Dr. Ramaris Herman. It's really been a great time with you guys. You guys made it interesting. I love that movie, Inside Out. And some of your visuals, because I think that's a good example of what happens in the brain, when kids are escalating and the parents are escalating too. We're people too.
Absolutely.
Your amygdala gets activated too, because you're perceiving it as a threat. It's amygdalas talking to amygdalas.
And remotes do get broken. I'm just going to say that. I can understand how parents can get to the point of the two different cars, because I think you just want to get peace sometimes. And I know you guys as psychologists are like, why? But I can see where that can happen, especially when you get more than one, because yes, it gets crazy. It gets crazy.
We understand.
Mr. John Williams said, this was very informative for me as a children's counselor. I have 32 years in the field of youth development and family services. I have witnessed so many children experience these disorders. This was awesome. Excellent presentation.
Thank you.
Wow, that's especially, and he has so much experience. So we appreciate everyone for being on the line. I put Ms. Cheryl Maxwell's information. I put the Irritable Kids information in the chat. We have our next Mind Health Shop Talk coming up June 20th, and it's going to be our men's mental health segment. So we'll go into a little bit of what men mental health trends are and how we can support them. So please come for that. And for this month, we have a few initiatives that I know, because we're short on time, that I just wanted to tell you about. May 26th, we're having a intimate conversation about bipolar disorder. We'll have two of our BMHA members, one who is a RN. She'll be talking about what she sees in her practice, and how one of the other members wrote a whole book on her experience with bipolar. So we'll have that on the 26th. We have a golf tournament coming up on the 10th that was rescheduled. That's why I've been so all over the place and not able to really do all the marketing that I would usually do. So that's going to be June 10th, and the follow-up email will give you our Survey Monkey. Please, please, please give us feedback so that we can keep this Mind Health Shop Talk series going. So yes, that's in the chat. And as soon as you guys close the Zoom, it also pops up. So thank you guys for joining us. Thank you, Dr. Herman, Dr. White. You guys have been a joy to work with, and I look forward to working. And Ms. Sung, thank you. We look forward to working with you guys later in the fall. Hopefully we can make our schedules work to make that happen.
Beautiful.
Thank you guys. Have a good night.
Thank you.
Thank you.
Thank you. Bye.
Work. Bye-bye.